Hello, welcome to the last couple chapters here at the end of the term. So we are finishing up with chapter 16, endocrine, which can be tough, and chapter 9, musculoskeletal disorders. So these will show up on the final, a heavy emphasis on endocrine on the final. It's not all your questions. Obviously, the final is cumulative and it's going to pull from all chapters, but there's probably a good, decent 20 or so questions that are just dedicated between these two chapters, especially a heavy focus on endocrine and diabetes. So look for the study guide for this and use that as your reference guide. But chapter 16, let's talk about the endocrine system. So, A&P review. Endocrine system is all about glands throughout our body that secrete hormones into our bloodstream. That's where the word endocrine comes from. Endo, it's like into. So, into the bloodstream is where they secrete their hormones. And mostly, endocrine system is about homeostasis. So, basically, a lot of the control is done by the hypothalamus with a little bit from the thalamus, but the hypothalamus is like the conductor, controls the pituitary gland, the posterior and anterior, and they secrete control over a lot of the other glands. Some of the glands that kind of have their own way of homeostatic control is definitely pancreas and adrenal glands, but all of them have an influence by the hypothalamus, and most of it's about homeostasis. So hormones are just chemical messengers. The nervous system operates with neurotransmitters. Endocrine system operates with these chemicals called hormones. The chemical structure of a hormone is either peptide or steroid hormones. So usually they call them either steroid hormones or non-steroid hormones. Steroid hormones are derived from lipids, proteins. Peptide or non-steroid hormones are derived from proteins, and it just means that they communicate with the cell a little bit differently. But all the cells where hormones will have an effect is on target receptors, and this is a homeostatic control done through a negative feedback system. So these are kind of like all of them major hormones and their primary effects. This is a good chart if you don't remember A&P. A&P is always going to be important. Um, but it gives you an idea of who secretes the hormone, where's the source, and that sort of stuff. You can see that our hypothalamus and our the adenohyphosis that's the anterior pituitary. That adenohyphosis is the name for the anterior pituitary. The anterior pituitary tends to secrete a lot of secreting hormones that are directed by the hypothalamus. So that's kind of its role, and then all the other hormones kind of directly come from the specific gland and then go to target places, and they're only going to react to cells that are have receptors for these specific hormones. But this is a good chart to kind of give you the big picture of all the major hormones and kind of what their effects are and what you should be thinking about. Now, control is really again through homeostasis and the negative feedback loop. So a lot of the endocrine system and nervous system kind of work together for general metabolic activities, but it's the negative feedback. So negative feedback is basically saying everything is mostly negative feedback except two unique options. Positive, so negative feedback is saying that the opposite happens. So if, for example, negative feedback loop and homeostasis is saying if you're cold, right? What's your body going to do? Your body and your hypothalamus are going to read that your blood is a little bit cold, and they're going to try to do the opposite. So the hormones that get released goal is to warm you up, and that's negative feedback. It's going to warm you up until you reach a set point, and then secretion of the hormones that are warming you stop. That's negative feedback, where the feedback our body gets is the opposite for the environment around us. Positive feedback means that the environment around us is causing something and we want to keep that happening. So blood clotting and childbirth are one of the only examples of positive feedback. Childbirth would be like, again, the woman's body hormones get released, oxytocin, and among other things, to make the uterus contract. And the uterus contracting also makes the body keep contracting. So it's positive, where it does that, doesn't have negative feedback. It's a positive loop where we want to continue the uterus contracting until the child is birthed. And same thing with blood clotting. We do that until the clot is formed. These are positive feedback loops. Everything else is negative, meaning we release something that's going to do the opposite of what the external sources in our body are doing. Like temperature is the best example to think about, right? You get cold, your body does the opposite, tries to warm you up until it reaches a set point. Some hormones act as antagonists. So some hormones are going to counteract other hormones to maintain a homeostasis and balance. So, for example, your thyroid gland and your parathyroid gland release calcitonin and parathyroid, and they both release calcium in a different way. One is trying to lower calcium blood levels, the other one's trying to raise them. Insulin and glucagon, both released by the pancreas. Insulin tries to lower blood levels of glucose. Glucagon tries to raise them. So it's a homeostatic balancing act. Again, most often hormones are controlled by negative feedback. Endocrine and nervous system work together in this. It's usually in a cyclical, like a cycle pattern. And this is kind of showing negative feedback where, right, I have a high glucose level. Say I just ate a piece of cake, right? My that high glucose level gets to the pancreas and it reads that and says, okay, well, we need insulin to grab that glucose and carry it out of bloodstream and store it in the cell. Yes. So it does that. Eventually, we're going to lower our blood glucose level because of insulin. Well, now the pancreas sees, okay, now the level of glucose in the blood has lowered. So it's lowered to a point that I need to counteract that. And it's ebb and flow of balance. And now I could release glucagon from the alpha cells in the pancreas, which is going to basically try and raise blood glucose and put it back into the bloodstream and kind of, again, this counterbalance all the time of homeostatic balance. So most endocrine disorders are all usually kind of representing two things. Usually they're for some reason there's excess hormones, or there's impaired feedback loops where the hormones don't get shut off, so to speak. The water faucet doesn't get turned off, kind of thing. Usually what makes excessive high levels of hormones are tumors. Tumors that pop up on certain glands can act like that gland and overproduce a certain hormone. Or excretion or storage of hormones is impaired because the liver can't metabolize or the kidneys can't get rid of things in the urine. And there's other just congenital defects that would cause excess hormones that people are predisposed to based on genetics. It kind of depends. On the other end, if it's hormone deficiency, we don't have enough. Again, tumor taking the place of effective endocrine tissue and not secreting the hormone, therefore not enough hormones released. Producing too much of an antagonist hormone, like a tumor on the pancreas that secretes too much glucagon, is always going to kind of keep our sugar high. Removal or destruction of the gland physically is going to delay hormones. So how do we figure some of this stuff out? A lot of it's going to be through blood work. We can check a lot of hormones through the blood. Urine can tell us a lot, but we can also do physical biopsies of tumors or do scans of the gland itself, see if the gland is destroyed in some way, see if the gland is swollen, see if there's a tumor, that sort of stuff. So one of the big, most common endocrine disorders is diabetes. Diabetes mellitus, DM is for short. So when you say diabetes, you're talking about the disease process is known as diabetes mellitus, basically, or mellitus, however you want to say it, mellitus, mellitus, but DM is diabetes. The basic problem for diabetes, there's two types of diabetes that we're going to talk about, but the problem is the same. The basic problem is either I don't have enough insulin or the receptors for my insulin have become resistant to it and not reading insulin anymore. But the chief problem with diabetes is always going to be abnormal carbohydrate, protein, and fat metabolism and excess amounts of glucose. So the main problem is usually always, either way, type 1 or type 2, is hyperglycemia, too much glucose in the bloodstream. And so insulin is important, and control regulation of this by the endocrine system is important. But the chief problem with diabetes is always going to be too much glucose. So the different types, you need to know the difference in type 1 and type 2 diabetes. This is A and P, but this always comes up. So you have to know the difference. So type 1 is usually characterized as an autoimmune disorder because our body generates antibodies that actually target specifically the beta cells of the pancreas. The beta cells are the ones that release insulin. So insulin either is not being produced very little or insulin is not produced at all by these patients. And so they require insulin replacement therapy. So that's why type 1 diabetes is sometimes typically known as insulin dependent diabetes mellitus or mellitus, because they are dependent on insulin. They do not make it. It's an autoimmune condition where they are struggling to make insulin. And so that's where you get diabetes mellitus. So a lot of times type 1 is known as insulin dependent diabetes mellitus. That's why. Um, and so usually this is a childhood onset or adolescence, so like teenage years to low, maybe even into early 20s, but that's a little more rare. It's not linked to obesity. It's not linked to taking too much sugar. That's what it's linked in childhood onset, genetic factors, and it's autoimmune. It has nothing to do with bad diet or anything like that. But this is a lifetime diagnosis. You cannot cure, you cannot get rid of type 1 diabetes. Type 2 is known as non-insulin dependent. Usually they say non-insulin dependent diabetes mellitus. Um, you can usually treat type 2 with an oral drug. They don't always require insulin. What causes it? It's a combination usually of maybe a decrease in insulin production and or increased resistance to the cells for the insulin, the reception, like the receptors of the cells. Typically, it more in lines with increased resistance, and that's why oral hypoglycemics, oral drugs designed to kind of treat blood sugar can be effective. Onset is slow and insidious, way different than acute onset, usually older than 50, but you could basically say anything older than 30 years old is more at risk. And this one's associated with obesity, metabolic syndrome. It has increasing in young adults and teens, but it's more associated with older age, obesity, poor diet, poor diet with high in elevated carbs and like complex carbs that aren't very easy to digest. So basically over time with fat distribution, that sort of stuff, diabetes develops, the cells become resistant to insulin because insulin gets secreted so much if someone's is overweight and has a high sugary diet, and then they develop type 2 diabetes. Type 2 diabetes is not really curable per se, but it is very much controllable, and it is reversible to the sense of losing weight, changing diet, changing lifestyle modification can get rid of type 2 diabetes. So back to type 1, it's all about kind of, again, early onset, childhood, adolescence, a lot of metabolic changes associated with that, basically with type 1 diabetics, because they don't make insulin. We tend to do a different type of, they tend to suffer from a different type of metabolism where they metabolize their fats and their proteins because they have so much sugar, they can't utilize all that sugar. And this metabolizing fat and proteins to use for energy over sugar creates these things called ketones. So ketones are an acid component. Ketones, when you hear ketones, you think acidity. Ketones are, again, a byproduct of we have so much sugar that our body has to utilize other things for energy. It's like it can't use all that sugar. And so it utilizes breakdown of fat and proteins, and that produces ketones, which are acidic components. And that causes ketonuria, that causes ketones in the urine, which is going to basically raise acid level, decrease pH, decrease bicarb, HCO3, because we got too much acid. And this turns into kind of metabolic acidotic state, which we know as DKA, diabetic keto acidosis, related to this buildup of ketones in the blood that we're trying to get rid of and so type 1 diabetics are much more prone to this. With type 2, again, we can control it usually. This is usually, again, later onset, 30 years old up to 50 years old, related to lack of exercise, obesity, poor diet, insulin resistant diabetes. So we can mess around with dietary intake, change body fat, kind of reduce insulin resistance by oral medications. We can stimulate the beta cells to produce more insulin. We can also give this patient insulin to help counteract if we need to. Just depends on the patient and the choices we need to make. And for control of type 2, it's about monitoring blood glucose, keeping it low, things the way to stimulate that. If they need insulin, they follow a proper insulin regimen would be helpful, and then kind of continued blood testing. So initial stage for any of the diabetes is fairly similar. The initial stage, again, the initial problem with diabetes, type 1 or type 2, is that they have too much sugar in their bloodstream. So whatever it is, if there's not enough insulin, like in type 1, or there's increased insulin resistance, blood levels of glucose are going to rise. That's known as hyperglycemia. You're going to find excess glucose in the urine. Um, you're going to find diuresis because of that, because your kidneys are trying to get rid of all this glucose. And that could lead to dehydration, thirst, electrolyte imbalances, that sort of stuff. Very similar kind of presentations for type 1 or type 2, either one. And so the general manifestations, we really talk about the 3 Ps of diabetes. So someone with diabetes is going to suffer from polyphagia, which is increased hunger, mainly because insulin deficiency or inability for the reception. Again, insulin resistance means there's decreased transport of glucose into cells, which we utilize for energy, which means the body tries to metabolize other things for energy, like fats and proteins. And we're not metabolizing glucose because it's just kind of stuck in the bloodstream. We either can't get it to the cells because we have type 1 and we don't make any insulin to transport glucose, or we make plenty of insulin in type 2, but our cells are not receptive to insulin, the hormone, and so that glucose never gets transported. So blood glucose levels rise. So the 3 Ps always of symptom wise manifestations. Polyphagia, why are we hungry? Well, we're hungry because no matter how much we eat, the glucose is not getting utilized for energy. So our body kind of doesn't understand. Our body just tries to make us more hungry to get more glucose because that's what our body thinks the problem is. We're going to have excess glucose in the urine, causing glucosuria. We're going to be peeing a lot of urine. So the other is polyuria. We're going to have increased amount of urine, polyuria, because our body's trying to get rid of that. And because we have polyuria, it's basically a hyposomnular like filtrate problem. Because we have polyuria, we're going to be continually losing other electrolytes like sodium and other things. And so we're also going to be dehydrated and thirsty. So we're going to have polydipsia. So those are the 3 Ps of kind of like manifestations of hyperglycemia, of high glucose, is polyphagia, polyuria, polydipsia. Going to be hungry, going to be excessively thirsty, and excessively peeing. And those are all related to glucose not getting into the cells like it's supposed to. Again, these would be the same things for manifestations for type 1 or type 2. It's the same problem. So diagnostic tests, we can do fasting blood glucose levels. That means you would take someone and do a glucose level check after they have fasted all night, haven't eaten anything, and see how high it is. If it's relatively high after not eating anything, that means that it's lingering longer than it should, and that can be a sign of diabetes diagnosis. Glucose tolerance test basically means giving someone a high sugary liquid and then seeing what their blood glucose level does afterwards. Are they able to bring it down on their own? If not, that would be indication. And then another kind of tried and true method is a lab work test called, this is the full name, glycosylated hemoglobin test, but most people know it as hemoglobin A1C. So hemoglobin A1C is basically a great test for glucose levels over months, because red blood cells and hemoglobin will stay alive for about 90 to 120 days. Right, that's their lifespan, because they don't have, remember, hemoglobin don't have a red blood cell, or I mean, excuse me, red blood cells don't have a nucleus, so when they're created, they have a short life for a reason, because they get used up a lot, and we want to be able to recycle them. And so their life is only 90 to 120 days, 3 or 4 months. And so hemoglobin A1C basically measures hemoglobin's carrying capacity of glucose over that time period. If hemoglobin A1C is a high, it indicates that the glucose have had to carry more glucose around longer than they should have. And this would be an indication of diabetes. So, again, it's kind of depends. You can call someone pre-diabetic. I think if it's 5.5 to like 6.4, and then 6.5 and above hemoglobin is considered you have diabetes, whether that's type 1 or type 2, that would depend. But for you guys, for this stage, just kind of know what hemoglobin A1C is measuring, that this is a main diagnostic test for diabetes mellitus. That's where you want to need to know there. So complications are related to usually related to, again, how much glucose is in the blood, how long it's there. Um, Complications can be acute or chronic. Going to change with levels of physical activity, change with diet and alcohol consumption. Could be nausea, vomiting. Infection is more prone. Skin injuries are more prone. Poor wound healing, that's kind of stuff. So acute complications, not chronic ones. The big one that people deal with a lot is hypoglycemia, too low of a sugar. You say, well, how's that? Because isn't their problem that they have too much sugar in their bloodstream? Yes. That means they're more easily, this balance is out of whack to the point that people with diabetes are much more prone to hypoglycemia, too little sugar in their blood. Mainly because of, again, medication regimens. They're much more fickle, so to speak. Their blood sugar is harder to control, and they're less likely to compensate better than other people that don't have diabetes. So when someone's blood glucose drops too far, we get disorientation, level of consciousness changes, um, anxiety, decreased responsiveness. They're going to have sweating, pallor, um, increased heart rate, decreased blood pressure, and just general change in level of consciousness. If hypoglycemia is lasting too long, if their sugar got too low, we could get to the point of leading to seizures, even a coma, then death, brain damage. So what are the problems? That's one of the things you got to watch out for with diabetes. Hypoglycemia is hard because they're just hard to control, and too many meds, or meds at the right meds without eating, or meds, like insulin therapy, subcutaneous or oral, oral hypoglycemics, oral meds that could try to decrease glucose. If we're doing any of those and not keeping up regimen wise or keeping up with eating, that can lead to hypoglycemia. So a couple of complications that arise that are more prone to type 1 and type 2 diabetics. The one that's more prone in type 1 diabetics is diabetic ketoacidosis, DKA. This is more occurring in insulin dependent clients, which again is type 1. Not having enough insulin, not making enough because of their beta cell destruction. They're going to have high glucose levels. And this kind of changes, again, the production or metabolism of lipids and proteins, creating ketones, and ketones build up. And then that leads to the polyuria and all that sort of stuff. This could be infection and stress. It just kind of depends. But DKA is going to be an acute response. That's going to be something that is, again, is going to lead to a metabolic acidosis state because the ketones build up and they cause ketones will basically cause acidosis because the ketone bodies are acidotic. They are an acid component, and that's going to use to struggle with that's going to be a struggle with the ability for someone to maintain that. That's going to send them into a full metabolic acidotic state, and we kind of know what that ends up being. That means, again, confusion, those sort of things. This is a chart that talks about development of DK. Again, basically, have decreased insulin. We're going to get the 3 Ps: hyperglycemia, leads to electrolyte imbalance, severe dehydration. At the same time, acidosis is developing, and then we get symptoms of metabolic acidosis. So we get the 3 Ps, the thirst, but we're also going to get signs of this extreme dehydration, dry mucous membranes, dry mouth, a warm kind of dry skin, tachycardia, but with weak, not really good pulse, blood pressure's low because of all the fluid loss, decreased urine output. That means that our body's trying to compensate, but may not be able to rush. And then there's things that are specific to DKA. The need to know for DKA is one thing that when you hear these on a test question, they're always trying to get you a DKA. One of them is called Kussmaul's respirations. These are rapid, so really fast rate, but very deep respirations. Kussmaul respirations are actually a metabolic acidosis compensation mechanism. Remember that metabolic acidosis means our kidneys are struggling. So our other body system that helps us regulate acid-base imbalances, right, is our lungs. So if the kidneys are struggling to deal with these ketones and all the urine output and the high glucose, so the kidneys are struggling to deal with this acidotic state. So the lungs will come in as a compensation mechanism, and they'll do Kussmaul's respirations, rapid, fast, deep respirations that blow off a lot of CO2, which is combines with acid. So we can try to correct acidosis that way. So Kussmaul respirations are this like forceful, deep respirations that are uncontrolled by the patient suffering DK. They're also going to have like acetone breath, which is basically sweet, fruity breath. You hear anything about fruity breath? The ketones produce this kind of breath smell. Lethargy, just decreased consciousness and responsiveness, decreased blood flow, those kind of things, coma, death. On a similar disease process, or simpler condition that happen, or similar condition that happens in more predominantly in type 2 diabetics is type 2 diabetics can develop DKA with the ketones, but typically type 2 diabetes, they produce insulin. It's just insulin resistance is the problem that makes their sugar high. So usually they get higher levels of sugar compared to type 1 diabetes, and they get it's usually also, you see this in more older clients. It's called HHNK or HHK. HHNK is hyperosmolar hypoglycemic non-ketotic coma or ketotic syndrome. What HHNK, or you can call it HHK, hyperosmolar ketotic or whatever, is basically a condition where excess extreme high glucose. So if you think of comparing, you need to know the difference between this DK and this DK. Like comparing it is going to be more prone in type 1, have a high sugar but not too high, and all the 3P signs: polyuria, polydysmia, polythirst, some dehydrations, a decent amount of fluid loss, but that metabolic acidosis symptoms, the fruity breath, the Kussmaul respirations, the pH that shows metabolic acidosis. An HHNK for type 2 diet is more prone in type 2, extremely high glucose level, where you could imagine type 1, 200, 300, which HHNK, you're going to see glucose levels of 6, 7, 800, extreme dehydration, extreme electrolyte and fluid loss. And the symptoms are going to be more related to the fluid and electrolyte loss. And it's not an acidotic. They're not going to have the acetone breath, free breath. They're not going to have ketones produced. It's not related to the metabolism. It's just related to the kidneys struggling to get rid of all this glucose. So extreme hyperglycemia, extreme dehydration, electrolytes imbalances. Need to know the difference. And electrolyte imbalances, again, potassium, sodium loss, sodium hyponatremia, so confusion, hyperkalemia, cardiac issues, that sort of stuff. Other complications around diabetes: chronic is a lot of vascular problems. Diabetes is making a high level of sugar in your blood that tends to cause a lot of issues with blood flow. So more prone to atherosclerosis development, definitely more prone in our small arteries. It affects a lot of places like the eye. There's a lot of small arteries in our eye. So there's a lot of retinopathy and retinal changes in the retina of the eye. So microangiopathy or microcirculation issues. So obstruction or atherosclerosis development or rupture of the small arteries that can be in our tissue. So tissue injuries, necrosis, neuropathy, lack of blood flow to the nerves. So they have decreases in sensation and decreases in pain, touch, sensation, feelings on the periphery, hands, feet, for example. Retinopathy. One of the leading causes of blindness actually in people is related to diabetic retinopathy. So the retina is very prone to blood flow changes. Those are small blood vessels. And then renal failure as well, overuse of the kidneys and lack of blood flow. Other chronic complications result in high levels of fat, so stroke, blood clot, heart attack, ulcer and leg development in the feet because of those microcirculation changes. And then those ulcers are slow healing. Everything about a diabetic is slow healing wounds, and they can frequent ulcers, that sort of stuff. Again, it goes to that what they call diabetic neuropathy. They're going to have peripheral neuropathy, the impaired sensation, numbness, tingling, weakness, impaired pain effect, that sort of stuff. Now, this is one of the most common problems, and this usually leads to development of those foot injuries. Patients with diabetes need to have very good foot care, need to not walk around barefoot, need to be more prone to keeping up with that sort of thing. So if I'm a nurse and I'm educating a patient about diabetes mellitus, what indicates that the patient has correct understanding of type 1 diabetes, correct understanding of type 1 diabetes? All right. You picked number two. You're correct. Autoimmune destruction. The rest of these are more talking about type 2. Type 2 is management with oral anti-diabetic medications. That's more, you're not going to find that in type 1. Um, Type 1, you can usually develops later in life and is about insulin resistance. Or type 2, excuse me. Type 2 is also associated with obesity and sedentary lifestyle. Type 1 is not associated with any of those. The only one talking about type 1 is autoimmune destruction of the beta cells and therefore almost no insulin production. Nurse caring for a patient with type 2 diabetes. What intervention is appropriate to manage hyperglycemia in this patient? What can we do to treat their high glucose level? Yeah, the only one that makes sense here is the one that's talking about this is the most common prescribed and most common oral med for treating type 2 diabetes is metformin, also known as glucophage. You probably heard of metformin before, but an oral anti-diabetic medication is always kind of the best treatment option to start with for type 2 to improve insulin sensitivity rather than jumping straight to insulin therapy. We would never encourage high carbs. We encourage low carbs, and we wouldn't give them glucose. So those don't make sense. The patient with diabetes reporting shaky, sweaty, irritable feeling. Nurse suspects hypoglycemia. What initial action should the nurse take? So, what should we do if someone's experiencing hypoglycemia? This one should be pretty straightforward. Yes, if you're thinking as a nurse, what's the first thing you're going to do? Assess their glucose level. You got to know what you're working with. Is their glucose level 50? Is it 60? That's a little low. You want anywhere from 70 to 120 milligrams per deciliter is the goal for blood sugar. 70 to 120, 110 milligrams per deciliter, depending on your facility you work at. So if their blood glucose in this situation is 30, that's concerning. Before we did anything, we would want to know what it is. We can't treat something we don't know what it is, right? Which manifestation is a characteristic of hyperglycemia in a patient with diabetes mellitus? So, um, which one of these talks about this is a symptom of high blood sugar? These are something you'd see in high blood sugar. Which one? This one was a little bit tougher if you pause and this one. Cool, clammy skin, bradycardia, hypotension, you're more likely to see in low blood sugar areas. High blood sugar, you're going to see, I feel funny, and you could see blurred vision because just think that the high sugar means the blood flow has turned into how is blood flow? Blood flow is liquidy, right? The blood flow has turned into like orange juice consistency to with high sugar levels to syrup consistency. And that's going to cause a lot of microvascular problems, which the eye is one of the first things noticed or is going to be affected by that. So, other endocrine disorders. Let's talk about the rest of the endocrine system. Diabetes, though, super, 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 super important. So, talk about the calcium regulation relationship. So, parathyroid hormone is one of the big hormones that regulates calcium. So, the hormones around your neck, anatomy wise, you have your thyroid hormone, which is about metabolism, and your parathyroid hormone are the small little hormones that kind of hang out on the posterior side of the thyroid gland. Its only job is to help us regulate calcium. So, parathyroid hormone is the only hormone the parathyroid gland releases, and its job is to raise blood calcium levels. Raise blood calcium levels. So where's my pen? Sorry. So, when hypoparathyroidism means that I'm not having PTH, is what you would call this. Parathyroid hormone is called PTH, which is good because PTH makes sense. Parathyroid hormone means that PTH levels are low. They're supposed to help raise blood calcium level, which means this leads to hypocalcemia, low levels of calcium. It's a little bit backwards, so you're going to kind of ignore this. Just ignore that. Ignore that. I hope you're listening to the video lecture. So it increases excitability of the nerves, spontaneous contractions of the muscles. So when you think of hypocalcemia, there's too little calcium in the blood. It's like there's too much in the cells. So it causes a condition known as tetany, where like the wrist locks up. It's going to cause jaw muscle spasms. So think of tetany, muscle spasms with hypocalcemia. What's going to cause it? Parathyroid gland's been removed on accident with thyroid surgery, or we had surgery for cancer of the thyroid. We did radiation. Autoimmune diseases could cause this. A tumor, again, is the causes of hormone disorders always fall into either tumors or removal of the gland or destruction of the gland, pretty much. And this kind of shows, again, the normal control and feedback is saying that calcium levels low, okay. PTH gets stimulated. Parathyroid gland says hello to the bones. Goes to the bones and says, hey, release some of your calcium in the bloodstream. Bones say, cool, we got plenty to go around. Goes to the liver, goes to the kidneys and says, kidneys, reabsorb more calcium. They say, cool. Goes to the digestive system, says, get all the calcium out of the food you can. Cool. Blood levels of calcium start to rise. PTH secretion stops. Bam. And again, same pathway. This is the normal control. If for some reason we add too much calcium, we had, say, a tumor, right? Tumor on the parathyroid gland acting like a parathyroid gland and secreting way too much PTH, that's going to raise our blood calcium levels up. And that would result in hypercalcemia. So hypercalcemia could lead to, kind of ignore this for a second, lead to kidney stone formation, osteoporosis, because it's pulling calcium. PTH pulls calcium from the bones to utilize. So pulling calcium from bones. And then generally, if there's too much calcium in the blood, we're going to have muscle weakness, not tetany or spasms, but muscle weakness, flaccid muscles. Think hypercalcemia, think decreased excitability in the muscle. That's what you want to think of. Again, could be from a tumor, could be some kind of neoplastic syndrome, cancer of the blood or cancer of the bone marrow. Possibly to come from renal failure, but it's a more rare condition because usually with this kind of stuff, you're going to think tumor. So if a patient exhibits muscle cramps, has tingling around their mouth, positive Chevek sign. So Chevek sign is basically, if I check their, how do I want to say? Chevek sign is basically checking just their tendon, and if their tendon locks up on their wrist and hand, that's Chevek sign. So what do you think they're experiencing? Pause the video to answer. If you said hypocalcemia, you're correct. These are all signs of hypocalcemia. Too little calcium in the blood means there's too much in the cells, too much muscle excitability, that sort of stuff. So if a nurse is assessing a patient that's confused, constipation, they're suffering with renal, they have multiple renal calculi, kidney stones, which electrolyte imbalance should the nurse suspect? Also, I'll say they got muscle weakness, flaccid muscles. This is pretty obvious. This is hypercalcemia. So more hormone imbalances. Pituitary. Some of the most common causes of pituitary disorders are linked to masses on the pituitary called adenomas, usually pituitary tumors. Pituitary is located just kind of around or above the base of the skull and brainstem, kind of on top of the brainstem. And so as a little like dangly thing off the hypothalamus. And so if it swells or there's issues around the pituitary, that could affect pressure in the brain. So that could cause increase in cranial pressure symptoms like headaches, changes in consciousness, seizures. But most of the problems with pituitary and adenomas is going to be dependent on what cell, what endocrine systems involved, that sort of stuff. Some of the big pituitary hormones that we see irregularities in is growth hormone. Growth hormone is one of the main hormones released by the anterior pituitary, and that's responsible for, yes, our growth from baby to adult, but it's also always responsible for growth. But you're going to see more effects from adenomas producing excess growth hormone or depriving the body of growth hormone. Obviously, in younger ages, children, adolescents, you'll see the effects more likely. So what's called pituitary dwarfism. Dwarfism usually is related to a pituitary issue where there's not enough growth hormone. A condition called gigantism. Gigantism is an excess growth hormone prior to puberty. And one other condition associated with gigantism is called acromegaly there. Acromegaly is excess growth hormone, usually in adults, associated with that adenoma tumor. And bones become like broader, heavier, more dense. And they also have bone or calcification of soft tissues around the feet, face, jaw, hands. Um, Sometimes gigantism sufferers develop acromegaly after the fact, where they basically have excess levels of growth hormone into adulthood. Why did this pop up here? Sorry, this question's here. I don't know why. Okay. Anyway, another thing to talk about is antidiuretic hormone. ADH and oxytocin are the main hormones that are released by the posterior side of our pituitary gland. Some of the conditions associated with ADH are worth knowing. There's basically two. There's what's called diabetes insipidus. One of my least favorite names. Diabetes insipidus, is basically not enough ADH. Do you remember what ADH does? ADH is anti-diuretic hormone. Anti-diuretic hormone. ADH. ADH is made by the hypothalamus, stored and secreted by the posterior pituitary, also known as neurohyphosis. The neurohyphosis secretes ADH. ADH targets the kidneys and says, hey, kidneys, we need some more fluid. So you reabsorb some water from the renal tubules, put it back in the bloodstream. So diabetes insipidus says, I don't have enough ADH being released for whatever reason. Again, adenoma on the pituitary, tumor on the pituitary causing not enough ADH release, whatever. So this also could be from head injury, genetic related, that sort of stuff. But diabetes insipidus is all about producing it. Without ADH, what happens? We don't retain fluid anymore. We produce a lot of urine now. Copious amounts of clear urine that leads to dehydration. Again, related to head injury, tumor, adenoma, something like that. And what's called inappropriate ADH. Sometimes it's called, this one over here on the right is the opposite. And sometimes it's called SIADH for short, but that stands for Syndrome of Inappropriate ADH, SIADH. SIADH is excess, too much ADH. DI, or diabetes insipidus, is too little ADH, so not enough fluid retention. This is too much. So too much fluid retention. This could be triggered by stress. Again, adenoma, tumor. We can treat this with diuretics and try to get rid of it, but it's going to think of just fluid overload symptoms. So edema, just all about jugular vein distension, hypervolemia. So jugular vein distension, excess fluid basically is SIADH. Thyroid disorders. There's mainly two thyroid hormones that we think about. There's T3 and T4 is how they're called, but they're just known as thyroid hormones. And they're all about metabolism. Thyroid hormones are about basically helping our cells boost energy, metabolize proteins effectively, generate proteins effectively. So thyroid hormones all about, think of whole body effect of metabolism and burning calories and like functional. So it's an important one. And thyroid also does release what's called calcitonin. Calcitonin is a hormone that's designed to decrease calcium blood levels to counteract parathyroid hormone, but it's not always released as often. Typically, parathyroid hormone is the one kind of in control of that system most of the time. But things that may develop is, again, pituitary and thyroid gland dysfunctions. Swollen thyroid in response to some of these conditions is called a goiter there, Goiter, goiter. Goiter, that word here, refers to enlargement of the thyroid gland, which is often like physically visible in the neck. And the reason a goiter, and this is kind of, again, I'm talking about stuff for a reason. The reason a goiter is something that is neat to know or interesting is that a goiter, being like a tumor on the thyroid or an overactive thyroid that is swelling, because the thyroid is a butterfly gland structure that sits kind of just inferior to the cricoid process, but the right under the main cartilage of your trachea and your neck. That's where your thyroid sits. And so, if I have a goiter, that means the thyroid's enlarged. That can lead to swelling that's pushing on your trachea, difficulty swallowing, pressure in the neck, pressure on blood vessels and nerve endings. It's a big deal to have a goiter because it's going to put a lot of pressure on some really important structures there in your neck, especially, your trachea, your windpipe. So there's two variations of thyroid disorders. Basically, there's too much thyroid hormone being released and too little. Too much is hyperthyroidism, also known as Graves' disease. Hypothyroidism is too little thyroid hormone being produced. Again, think thyroid hormone all about metabolism, energy burning. So hypothyroidism just doesn't necessarily get its own fun name. It's just too little thyroid hormone. It doesn't get its fun name like Graves' disease. So Graves' disease is neat to know. Hyperthyroidism, usually related to autoimmune disorders, possibly thyroid tumors, but hypermetabolism, increased stimulation of our central nervous system, basically, or our systematic nervous system, basically increased metabolic effects. So one condition that everyone hears about with hyperthyroidism is exothalamus. You don't always see this in hyperthyroidism, but exothalamus is presence of protruding, kind of staring eyes, decreases the ability of eye movement and blinking, a lot of tissue and swelling mass around the eye, and it could result in visual impairment. This is exothalamus to a very frank degree. You don't always see this, but think of exothalamus as the key weird symptom with that, but it's increased everything. This is the person that's like, I got up at 5 a.m. and I walked my dog and I da 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 da. Okay, this might be a morning person, but it could also be someone with hyperthyroidism, increased energy, increased metabolism, trouble sleeping, family history of thyroid disorders, that sort of stuff. Hypothyroidism, remember, hypo means low and slow, could be a number of things. It could be related to an iodine deficiency. We get iodine from our diet, and iodine is what chemical component is used to generate thyroid hormone. There's also something called Hashimoto's thyroiditis. Hashimoto's thyroiditis is a thyroid disorder where it's just autoimmune destruction. Hashimoto's thyroiditis is an autoimmune destruction of the thyroid. And the reason I'm highlighting is because it's a little bit weird where typically with this one, you'll see higher levels of thyroid stimulating hormone from the pituitary called TSH, thyroid stimulating hormone made by the pituitary. Pituitary makes a hormone that stimulates the thyroid to do what it's supposed to, but you'll see high TSH levels because the pituitary is trying to get the thyroid to do what it wants. And you'll see low levels of the T3 and T4 because the Hashimoto's thyroiditis means that inflammation has kind of destroyed the thyroid. Could be a tumor on the gland itself. And cretinism, I kind of say it cretinism, but cretinism is basically kind of a dwarfism or shortened stature that develops from lacking a thyroid hormone, basically born without a thyroid hormone. So cretinism, born without thyroid hormones, means they won't have the metabolism that they should, and they're going to have basically severe hypothyroidism, iodine deficiency, maybe in pregnancy leads to this, but they don't develop a fully functioning thyroid, and they're going to have short stature, usually cognitive deficits, that sort of stuff. Thyroid disorders like Hashimoto's thyroiditis and general hypothyroidism typically develop in women. General development of hypothyroidism that has has an idiopathic etiology and no real known etiology usually develops in older women. Manifestations with hyperthyroidism could have a goiter because the thyroid is working so hard, especially if I'm iodine deficient. The thyroid might bulge. Usually intolerance to cold, weight gain, lethargy, extreme fatigue, decreased appetite, something called myasthenia. is kind of severe. This is basically not myxedemia is non-pitting edema, so generalized edema and swelling to the face and through the tongue as well. Myedemia can like cause severe hypotension, hypoglycemia, and hypothermia if it's left untreated. But they'll also have symptoms like think of everything's not metabolizing right, so extreme fatigue, no appetite, intolerance to cold, brittle nails, hair loss, numbness and tingling in the fingers, that sort of stuff. So hyperthyroidism versus hyper. This is a good chart to kind of talk about what you're going to see. Typically, the metabolic rate's going to be low, weight gain, cold intolerance, that sort of stuff is where you're going to see there. So, which clinical finding is associated with hypothyroidism? If you said cold intolerance, you're right. Tachycardia, weight loss, excessive sweating, heat intolerance. These are all hyperthyroidism stuff. Patient came into heat intolerance, weight loss, and exothalamus, bulging eyes. The manifestations are indicative of, yeah, hyperthyroidism. So, kind of trying to round this stuff up. Adrenal glands. The adrenal glands are the glands on the the top of our kidneys. Adrenal glands. There's a couple different diseases: Cushing's and Addison's disease. Adrenal medulla is this interior part, or excuse me, yeah, the adrenal medulla is the interior part of the adrenal gland, and this typically is where our catecholamines are produced. So your adrenaline drug, your adrenaline drugs, your adrenaline hormones, epinephrine and norepinephrine, known as catecholamines, are produced in the adrenal medulla. So we have a tumor down there. It does overproduction of those adrenaline hormones, and it's called a phenochromoscytoma. Very rare. I think Dr. House had an episode about phenochromoscytoma. Phenochromoscytomas will produce excess levels of cortisol and stress response hormones and adrenaline and testosterone and all kinds of random stuff and cause like aggression and just random symptoms. They're more rare, but so phenochromoscytoma, yeah, it could be a tumor. It's going to increase these catecholamines, heart palpitations, sweating, anxiety, anger, personality changes. The more we're going to focus on is the adrenal cortex part. These are where we see excess. These are the hormones in the adrenal cortex, like Cushing's, aldosterone, or excuse me, Cushing's is the disorder. You'll see cortisol, the hormone, aldosterone, um, mineral corticoids, the glucocorticoids. So aldosterone, blanking on stuff here. Some of the sex hormones, sex steroids that we have as well get released by the adrenal cortex. So Cushing's and Addison's are kind of the opposites, and then mostly associated with excess levels of the glucocorticoid known as cortisol. Cortisol is also to help us deal with our stress response, and it's produced by the adrenal cortex. Cortisol helps us maintain stress by kind of raising our awareness and having a central nervous system effect. So with Cushing syndrome, the person's going to have change in appearance often. They're going to have redistribution of fat. Fat's going to turn from like maybe around the waist where we typically think it and go to others. So they're going to have like thinner arms, thin, fatigue, frail skin, thin hair, striae is stretch marks, truncal obesity. Again, fat tends to redistribute it, causes this rounding face with discoloration of the skin, fat around the abdomen and around the posterior flanks and that sort of stuff, thin hair, thin skin, stretch marks. Cortisol also, because that same area, wherever the same area in the adrenal cortex also releases aldosterone. So if there's a tumor there that's causing Cushing's, it's also going to cause excess aldosterone release, and that's going to lead to sodium and water retention, suppressed cause. Again, it's a steroid. It affects our immune system. They're going to have basically emotional changes. different delayed healing, different decrease in metabolism, increased insulin resistance, so diabetes development possibly alongside all this. And this kind of shows it, like thinning hair, mood swings, insomnia, moon face, um, hitcherism is one thing. As this happens in women, it would develop like uh, hair on the chest, facial hair, breast hair on the breast, that sort of stuff. Redistribution of fat is what they're talking about with buffalo hump. Fat pads, fat development tends to redistribute, goes truncal around the waist, goes up to the shoulders. Excessive bruising, um, hair loss in places, fragile skin, poor wound healing, that sort of stuff. That's Cushing's. Addison's is excess of that adrenal corticoid steroid. So excess of that hormone, excess, or excuse me, deficiency. I'm saying the wrong thing. Cortisol excess is Cushing. So if you want to remember Cushing's, you think of that hormone that's produced, that steroid hormone called cortisol that helps us deal with stress. That cortisol is an excess level. So Cushing's equals too much cortisol. Addison's means not enough cortisol, not enough of that adrenal cortex hormones. Usually it's autoimmune related, but or destruction of the adrenal gland. But they're gonna have like decreased glucose levels, inappropriate stress responses, weight loss, low sodium, low blood volume, hypotension, um, usually high hyperkalemia, high sodium. So they're also going to have this hyperpigmentation. So they're going to have changes in their skin tone and color, that sort of stuff. Um, Anorexia, nausea, poor stress response, hypotension, syncope, so dizziness and passing out. So a patient presents with hyperpigmentation, hypotension, electrolyte imbalances. Which endocrine disorder is most likely? This one is Addison's. Cushing's would be frequent bruising, frequent wounds, poor wound healing, redistribution of fat, um, moon face, buffalo hump is that redistribution of fat, thin arms, increased truncal fat, increased fat around the midline, thinning hair. That's all Cushing's. So these are much more rare conditions, but they are possible. So that kind of wraps up our endocrine chapter. Thank you guys for watching. And let me know if you have any questions. I know this one can be confusing.